Next, I would like to introduce Dr. Lynn Schuchter, who's the chief of our division of hematology oncology and is the chair for this activity. She's also the director of the Tara Miller Melanoma Center and really leads us every day and has kept us strong and focused during the pandemic. So please welcome our fearless leader, Dr. Schuchter.
Thank you so much. And thank you everyone for joining us tonight. I think it's been just a wealth of information. I'm going to switch gears a bit and focus on more the delivery of cancer care during the COVID-19 pandemic and really sharing our experiences here at Penn Medicine and sharing some of the national guidelines that have been established. And we have some overarching principles that we're considering. One is the timely and high quality of cancer patients that needs to continue. We want to protect our patients from COVID-19 infection. We want to reduce their complications. And of course, we want to protect all of the physicians, nurses, and our healthcare workers. And I've been thinking about the evolution of cancer care during the pandemic. This evolution is a very short period of time, over a 6 to 7 month period. But at the beginning of COVID, we really were focused on creating capacities in our hospitals to be able to care for the potential surge of patients with COVID-19 infection. And we actually were downscaling on cancer care. We were forming multidisciplinary teams to see how we could modify treatment regimens, which patients could be postponed or have their treatment delayed. We were doing no cancer screening and a lot of crisis management and trying to really establish the best protocols for safety for our patients and healthcare workers. Now we're entering, I think, more of a COVID stable, although I a little bit hesitate to use that word because this is still a very dynamic situation. But we're now in a phase where we're providing cancer care and really coexisting with COVID. We figured out how to switch to telemedicine. We've reestablished cancer screening, but as Dr. Fauci and others mentioned, not to the levels we need. And we're going to get to a new future state, which I'll speak to at the end. And I just want to mention, this is similar to our experience here at Penn that many of you have. I'm showing you here the occupancy rates of our hospital. And this was, we are a very full hospital. And in the spring, when we had our peak of the epidemic here, our capacity at our main hospital went down to 40%. Well, what we all had to do to create this capacity really affected how we deliver cancer care to create this capacity and the difficult decisions we had to make about those adjustments. And in oncology, here and just like all of your practices, we really were open and we needed to continue to provide care for oncology patients. And that didn't stop during the pandemic. And you see really relatively flat numbers here in terms of our visits. But what did change during our peak is this very rapid switch to telehealth. And many of us have adopted this new way of delivering care, which has been, I think, quite effective in many situations. And now we're at this phase where at the peak, maybe we were 60 to 70% of our patients were telehealth. And now we're back to about 80% of our patients in clinic in face-to-face visits and only 20% of patients getting their care via telehealth. I'm not going to go through all of this, but now our goal is really to optimize patient and staff safety, and importantly, optimize the opportunity for cure. And we have a number of roles that we all play. First, I want to emphasize the importance of educating our patients on the symptoms of COVID-19 and their protection. And I think because of this education and reinforcing the importance of social distancing and mask wearing, that's why we've seen a relatively low incidence of COVID-19 in cancer patients. I mean, national estimates are that about 1 to 4% of patients with cancer have experienced an infection with COVID-19. Our data here shows a little bit less than that, less than 2%. We've done a lot to redesign our ambulatory clinics, and I think really essential for all places is that we have this designated area to effectively evaluate patients with fever and patients who may have symptoms related to COVID-19. This is especially necessary as we enter the fall and winter, where patients are going to come in with flu. And these patients need to be in a specific area away from the rest of the ambulatory population. Frequent use of multidisciplinary tumor boards, which I think have been more important than ever, with broad representation of radiation oncology, surgery, medical oncology. As we've made these adjustments in how we make treatment decisions, we've seen more use of tumor boards, which are now virtual, and we can include more people. And we've understood that we have to individualize our discussions about risk and benefit of treatment in an individual patient with cancer, depending upon the stage, et cetera. But what we know is that it is safe to give treatment, and routinely holding treatment is not recommended for our patients. And we need to continue to deliver this in a safe way. So I want to touch on sort of three big points that we face every day. First, who should have COVID testing in our patient population? Well, obviously, patients with symptoms. We've heard much about that: fever, cough, and other symptoms. But this is especially hard in our oncology patients. The differential diagnosis is more difficult because there's an overlap of COVID-19 symptoms with other infections that our patients may have, complications of treatment, or their disease. So very difficult sometimes to make that distinction. But when we're testing patients for COVID-19 in a symptomatic patient, this needs to be done in a designated hot zone away from patients who we don't suspect to have an infection. Then how about in patients who don't have symptoms? So there are no national recommendations about who should be tested, but I would say that there's growing consensus, and I'm sharing with you what we're doing here at Penn, and similar to ASCO guidelines and NCCN. So we are doing COVID-19 testing in patients who are undergoing a stem cell transplant, any type, those that are undergoing cellular therapy, those patients that are getting admitted for chemotherapy, and to the hospital. We're doing pre-admission COVID-19 testing. These are usually acute leukemia and lymphoma. And we are doing testing for every patient who starts radiation therapy. There's a growing question about patients with certain types of lymphoma and regimens because of the therapies that are directed towards B cells. Maybe this really is a patient population that is more susceptible to severe complications of COVID or incidents. So there's a question, and some centers have adopted testing in these patients. And obviously testing in this situation is in a cold zone, not where patients are symptomatic and could have the infection. And there were also testing prior to cancer surgery, any invasive procedure, especially an aerosolizing procedure, that's done generally 3 days prior to this procedure and done in a cold zone. Now, as I mentioned, it's still not common for patients with cancer to have a COVID-19 positive and develop coronavirus. But what do we know about their care? I mean, in general, the approach to treating the COVID-19 infection is similar to other patient populations, but just to add that these patients often become sick quickly. So we have the experience of someone looking well in clinic, we get a test, and 24 hours later, they're in the MICU. So the acuity can change very rapidly. We generally hold active anti-cancer treatment if someone tests positive for COVID-19. Now, there are situations that you may not be able to interrupt: induction leukemia. There's certainly situations in the middle of a radiation therapy where you may not choose to hold that treatment, and that's going to be really individualized clinical decision making. It's really essential that we are much more proactive on advanced care planning. We've heard the data: patients with advanced cancer, older age, advanced stages of cancer, if they get COVID-19, a very high mortality rate. So it's important for us to have early conversations about goals of care and what patients' wishes are. Then in terms of resuming cancer therapy safely, Kathleen touched on this a bit, but at the beginning of the pandemic, we were using more of a test-based strategy, and we needed to see 2 negative tests before we would resume treatment. But as she mentioned, these molecular tests can remain positive for some time, though not infectious. And we certainly saw that patients had considerable delays in resuming their treatment. So now it really is a time-based strategy. And so the recommendations, and this is in conjunction with our own infectious disease and with the CDC, and really growing national consensus about using time-based, that you wait at least 10 days that have passed since the symptoms first appeared, at least 24 hours have passed since the last fever, and that symptoms are generally improving. That's a group of patients that we would say we could begin to consider resuming therapy when we held it because of an infection. If patients were very severe or critically ill with COVID, one could wait up to 20 days because these patients may be sicker. And that really begins to reach the limits of when we continue to see infections that can be transmitted. Sometimes we would use a test-based strategy in this situation too, before saying really is safe for someone to return to therapy, depending upon how ill they were. I just want to also mention just ongoing day-to-day challenges that I think are facing all of you. One is the consistent implementation of the safety practices. So we've said we want our patients back. We want to create a really safe environment. But this can be challenging, and I think people are getting weary, and we need to really continue to model the very best behavior. We're challenged with patients and staff not always wearing masks appropriately. And I will say this is a tension in a clinic area of trying to facilitate people wearing masks appropriately. But this is really critical to the safety of our patients. I'll just say we have a lot of signage here, and we've been very careful about moving the furniture so that we, again, create a very safe environment. But people are moving the furniture together, and so we literally are making signs, please don't move the furniture. I just want to also touch on this issue of visitors for our oncology patients. It still is very restrictive, and this is still very challenging, but we think this is the safest way to go right now. We're allowing one visitor in the hospital for our cancer patients, and in the outpatient setting, it's very limited. Many of our patients are not allowed to bring visitors back. We make exceptions, such as a new patient delivering bad news. The patient is frail, difficulty understanding. But I would say that this is still really hard. There are a lot of emotional needs of our patients, and we continue to look at this policy. But as we move into the fall and winter, and as we're seeing rising positivity rates, at the moment, we're continuing these restrictions, which I know is really hard for the providers, for the patients, and for their families. And just to begin to conclude, it's also really been an emotional toll on healthcare providers. And just at this year's ESMO, they presented the first survey of healthcare workers showing the tremendous burnout. And I'm showing you this graph, which shows the emotional response to disaster. And we were certainly in the heroic phase, and we see the cheering in New York City and then the honeymoon phase. But I know many of you shared with me the disillusionment phase as this was getting really hard. And I think we are resilient. We certainly, as oncologists, providers, are resilient. And we have a lot more time that we're going to be coexisting with COVID. And so all of us working together to take care of each other as we're through this period is really essential. Silver lining of some innovations in cancer care driven by COVID, really the rapid adoption of telemedicine, which I think is here to stay, has been fantastic. And as Charu briefly mentioned, we've successfully shifted some inpatient regimens to home safely, some outpatient regimens to home. And this has been a win-win for our patients and their families, and it's been safe. And I think this will continue. And so just to conclude, the future state, I think there's important things that we really have to understand. So many speakers tonight have touched on that we've modified treatment regimens and we've delayed therapy. We really have to understand the outcomes in our cancer patients in terms of survival, about these delays and what the impact is going to be. We're really concerned about the delays in cancer screening, and at our own here at Penn Medicine, we're not back up to the levels that we previously have seen. So again, important for us to encourage patients. It's safe to come in. And this is really important for us to understand the impact. Huge hit on clinical trials and cancer research. That's really important for us to get this up and running. We will need regulatory and payment models to modify so that we can support telemedicine. This has been a great advantage, and I think will be here to stay and will be very helpful for our patients. And really critical for our organizations to remain creating a capacity to really deal with these dynamic up and downs of scaling up and scaling down as we provide care for our patients. So I know that we can do this safely, and it's really important that we do this. Thank you so much.